Hi, I'm Mohammed Jahanzeb. I'm a medical oncologist in Boca Raton, Florida. I focus on lung cancer and breast cancer, and I work with Florida Precision Oncology, a division of 21st Century Oncology.
Hi, I'm Dr. Benjamin Levy, and I'm associate professor at Johns Hopkins School of Medicine. I'm a thoracic medical oncologist. I'm also the clinical director for the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C.
I'm Michael Lanuti. I'm a thoracic surgeon at Mass General Hospital. I'm the director of thoracic oncology in our division of thoracic surgery, and I'm an associate professor at Harvard Medical School.
Hi, I'm Cliff Robinson. I'm a radiation oncologist at Washington University in St. Louis. I am chief of thoracic radiation oncology and stereotactic body radiotherapy and director of clinical trials.
Hi, I'm Michelle Ginsberg. I'm a radiologist and I'm director of cardiothoracic imaging and vice chair for education at Memorial Sloan Kettering Cancer Center in New York City.
Let's go to our eighth and final case and give the floor to Dr. Robinson to discuss isolated hilar recurrence following wedge resection for pathologic T2NX non-small cell lung cancer.
Yeah,
Dr.
thank
Robinson.
you. I think this should nicely round out our cases for today as you see some common themes emerging. So here we have an elderly 80-year-old gentleman who, independent of the cancer of record today, had a remote history of a high-grade urothelial cancer that was of an advanced stage, a pathologic T3A. He had had a cystoprostatectomy and an ileal conduit over a year ago, and was doing reasonably well from that, but that's still a considerable operation to undergo. As part of his follow-up imaging, a lung abnormality was found, which we'll see in a moment. As I mentioned, he's doing reasonably well with his prior cancer. He didn't receive any adjuvant therapy for that. He's having no major issues, and overall ECOG would be 1, I'd say 1 to 2. So the medical history is as mentioned here. Again, no prior history of radiation. He didn't receive any adjuvant therapy for his urothelial cancer. Has a remote smoking history, quit almost many years ago. Continues to drink occasionally and is retired and at home. He does actually have a history of a brother and daughter with lung cancer, sister with breast cancer, and his pulmonary function tests are here. Again, 2.3 liters, 79% are predicted, and a DLCO of 65%. So here's the diagnostic imaging, and this is I'll just say that outside of this region, that he has no evidence of recurrence of his urothelial cancer in the pelvis or otherwise.
Yeah, here we see a 1.6 by 1 centimeter right middle lobe nodule, which is FPG avid with an SUV of 18.5. And in the bottom left-hand corner, we see the images from a biopsy that targeted that right middle lobe nodule.
Thank you.
Yeah. So the final pathology, as mentioned in the specimen from the CT guided biopsy, was an adenocarcinoma consistent with lung primary. No additional molecular subtyping was accomplished. Just to move this along, in light of his good pulmonary function and trying to obviate the question of any other issues, he underwent a VATS surgery. I think the surgery is worth discussing probably at this point. Overall, the surgeon felt that it would be difficult for him to tolerate a lobectomy, and he also did not offer a non-lobectomy anatomic resection. So he had a wedge resection. He also did not undergo nodal sampling in this case. The final pathology revealed an invasive adenocarcinoma, 1.5 centimeters with visceral pleural invasion, but margins were negative. And so this was deemed a pathologic T2NX adenocarcinoma, and he tolerated the surgery quite well.
So let me ask Dr. Lanuti to comment on it. And again, it's very difficult to comment without being there as to whether you would have followed the same course or you would have tried more aggressively to sample lymph nodes or to do something more than wedge resection, and educate us a little bit on wedge resection versus lobectomy pros and cons.
Yeah. And then I just want to ask Dr. Robinson, this was a right middle lobe lesion or upper lobe?
Middle
Middle.
lobe.
So that's pertinent because as we all know, the middle lobe is the smallest lobe anatomically in the body, and most patients, even though they have perhaps limited function, can tolerate a middle lobectomy. And so I will often, if I'm worried about the aggressiveness of a lesion, I think, that segmentectomy, if you will, is a middle lobectomy. And segmentectomy is clearly better than wedge. So we can talk about that data in a second. But in this case, if you're going to do something that's sublobar, be it segmentectomy or wedge, it behooves the surgeon to sample nodes. And that is a common theme throughout the US, is that when people are choosing something less than lobectomy, they're often less excited about sampling nodes. So that is something I always counsel my residents on: sample nodes always. Regarding, what is the difference between a wedge, a segment, and a lobe? Our data is old. It's being updated now with some randomized studies looking at 2 centimeters or less lesions. Our data goes back 2.5 decades, 1995, that a lobectomy had better local control compared to a wedge and a segment. That was in an era where there was no PET scan. They used bone scans. And that was for T1 tumors that were 3 centimeters or less. So can you extrapolate that to small tumors now in the advent or in the era of very good imaging tools? I'd say you can't extrapolate, and that's why we need prospective studies that are going to read out this year and next year for 2 centimeters or less randomized, looking at wedge, segment, or lobe. But the dogma is lobectomy is better than wedge, with the wedge resection giving you 3 times the risk of recurrence compared to a lobe. If you looked at that carefully in the analysis of survival, there was no big difference in survival when they did the analysis, but a lot of those patients were salvaged if they did recur. So our data is old and weak, but in this case, I would have preferred either a middle lobectomy if you had a frozen that showed you aggressive histology, and definitely sample nodes. I would not have done necessarily invasive mediastinal staging for this small peripheral lesion, as long as the PET was negative on the pre-op.
Great, that's very helpful. Dr. Levy, this pleural involvement, does that push your hand even in stage 1 lung cancer in any way?
I need to ask exactly what the pleural thickening seen on the scan, or documented pleural disease?
Seems like pathologically documented visceral pleural invasion.
Oh, the PL2, yeah. So that has changed the staging, yes. The visceral pleural involvement has changed the staging in the 8th edition. This is now a T2. And we run into issues about what to do with these patients because it translates a lot of patients into 1Bs where there's questionable data on adjuvant chemotherapy. I still do look at size as the criteria to deliver perioperative chemotherapy, a 4 centimeter. The visceral pleural invasion is thought to be a poor prognostic indicator, but it doesn't necessarily sway me if the tumor size is less than 4 centimeters.
I see. Any other risk factors that you consider in 1B worthy of chemotherapy?
So I would say poorly differentiated tumors, we consider whether or not visceral pleural invasion are 2 of the ones that are commonly seen. There's a few more. I'm whether you want to look at mutational analysis to see if something like KRAS mutations are again, we test everyone in the early stage, and there's been data to suggest that doesn't necessarily mean that they will do worse. But the poorly differentiated visceral pleural invasion are 2 of the ones that are commonly looked at. Inside.
And if the patient was 40 years old, would that sway you?
The patient were 40 years old?
Yeah.
Not necessarily. I think that chemotherapy can do harm in some patients, and it wouldn't necessarily. We try to go by what the guidelines are, and we are really still in the dark ages.
Yeah.
Who benefits from 1B? Who are those patients that actually benefit? Who benefits in patients that are 2 as well? It's unclear.
I see. So anything else on this slide, Dr. Robinson, or can we go?
So here's his additional follow-up diagnostic workup. So you can see the images, and just to calibrate for Dr. Ginsburg here, the left uppermost image is the relevant current image, but by comparison, I put it next to the one 6 months before that. And then we have an updated PET scan as well.
So in the current study, we see that the right hilar lymph node is new compared to the prior from 6 months ago, or at least there was a tiny lymph node, but not by CT criteria would not be called enlarged. And this lymph node is now SUV avid. I mean, it is avid with an SUV of 9.2, and there were no other lymph nodes. So this is a right hilar lymph node that's probably metastatic.
Yeah, so the PET scan revealed no other evidence of disease anywhere else except this right hilar node. And so they underwent EBUS FNA. Again, an attempt at slightly more comprehensive lymph node sampling was attempted. So stations 4 and 7 were negative, so the central N2 nodes were negative. However, 11R revealed adenocarcinoma consistent with their original surgically resected primary. So the question here then would be, in the patient with isolated hilar lymph node recurrence, what's the optimal management strategy?
So, Dr. Lanuti, if the patient was not good enough for surgery or more surgery before, would you attempt something here?
Yeah, it's a very intriguing question about what do you do with isolated lymph node recurrence that's regional. So there's ways to think about it. Is there in-transit metastases in the current lobe that you're missing? And that would argue for some local therapy like surgery. Is there a role for surgery to do completion lobectomy and then remove the regional lymph nodes for local control? And is that any better than giving someone other modalities like radiation or combining radiation with chemo? I think that's actually not quite clear for recurrence for us. But it's often in the board reviews, or it's in the tumor boards. We go through this debate. I think if someone is fit enough, we might offer completion lobectomy with sort of lymphadenectomy, but they have to be a very fit patient. In this particular patient, I don't know if I'd offer it.
So, Dr. Levy, as soon as Dr. Lanuti turns the patient down for surgery, and now you and Dr. Robinson are left to do something, do you think that you would consider this just like an inoperable stage 3 or inoperable stage 2 lung cancer and do concurrent chemoradiotherapy, or would you let him just do his magic with SPRT and wait for something else to happen? What's your approach in these situations?
As soon as Dr. Lanuti turns it over to me, I turn it over to Dr. Robinson.
Okay.
And I mean, this happens all the time. And I want the radiation, I mean, the radiation oncologist, really, given the advent of newer radiation techniques, again, this is a central recurrence, it's nodal. Is there a role for different types of radiation techniques? This is where I really first look to the radiation oncologist and say, can you deliver something that has a reasonable disease control rate that can lead to cure? And I'll let Dr. Robinson take that answer away before I talk about whether we should offer concurrent chemoradiation.
Okay, Dr.
Yeah,
Robinson.
no, I think it's a super fair question, and it's highly controversial within our own field as well. So, notwithstanding the radiation techniques, this patient did develop a nodal recurrence and is at risk of further recurrence as well. So while my main benefit is going to be in providing local control, one could make the argument that in the absence of other therapies that, we may be missing an opportunity to prevent further recurrence, but we don't have any evidence of that. So as it relates to controlling this with radiation alone, one of the core things we learned early on with SBRT is that as you start to approach the central and then so-called ultracentral structures where you're knuckled into the hilum or close to the main vessels or esophagus, the risk of toxicity with traditional regimens is unacceptably high. And so you need to alter your dose and fractionation strategy. So this is a case where if we gave something, this would be like the prior case where we might consider a so-called hypofractionated, but not true SBRT treatment, where we use the core principles of keeping a confined dose distribution, rapid dose fall off, higher dose per fraction, but not something that'd be liable to cause a fistula. And so this would be somebody where we would give, say, 12 to 15 radiation treatments, and some places in Europe might do it over 8. Again, though, that is only in the absence of chemotherapy. That would not be safe with cytotoxic chemotherapy.
So what systemic therapy would you offer, Dr. Levy?
Yeah, I think if we're talking about definitive chemoradiation in this case, I would offer weekly carbotaxol with the radiation if we decide to do both together. If radiation for some reason is off the table and we're just looking at systemic therapy alone, that's where I think molecular analysis would be critical. If we're only able to offer chemo, maybe we can get away with doing something genotype directed. But if Dr. Robinson agrees that we're not going to do a hyperfractionated approach, we're going to do definitive radiation, then I would offer weekly carbotaxol. And again, similar to the last case, consider durvalumab on the back end, even though this is not truly a stage 3 cancer.
You're exactly right that principles of systemic therapy would still apply. And if we accept the fact that cancer takes people's lives by its spread, not by where the actual tumor starts most of the time, that one would think in that direction. This has been a truly enlightening discussion. I thank all of you. These were phenomenal cases, all requiring multidisciplinary input, and it's such a treat to have world-renowned experts discussing them and coming to a consensus. Thank you all.